Welcome to today's class. I am Dr. Naveen Devi, Senior Resident in SLIMS. Today we'll be discussing on Wilson's disease. So, Wilson's disease is a disorder of intermediate metabolism. You can't pinpoint it to one particular system. It's also a systemic disease. But mainly it involves the liver and the CNS. So, let's get into it. It's a disease of metabolism, and it involves the copper metabolism. So first we are going to discuss something about copper. So copper is present in a lot of the foods that we eat. Most commonly, it is seen in foods like vegetables, like green leafy vegetables and potatoes. It can be seen in chocolates, nuts, and it can also be seen in lots of seafood like oyster and shellfish. So these are some of the dietary sources where we can get a lot of copper. And this will be much more important when we go back and read about the treatment uh, regarding Wilson's disease. And the required daily dietary elements for copper for a normal adult is between zero point 0.9 to 1.5 milligrams per day. So, and that we get from all these various sources. And when we eat these food, and this food in this food, the copper is in Cu2 plus form. So from that, it gets reduced by the once it enters into the gut. Partially, it gets absorbed in the acidic environment of the stomach. After, but the largest amount of absorption of copper happens in the duodenum or in the ileum. So between the duodenum and the ileum, in the small intestine, the largest absorption of copper is happening. And before absorption, this copper that is in the food, which is in Cu2 plus form, is converted into the Cu1 plus form by the reductase that is present on the blood border cells of the enterocytes. And there are two mechanisms. There are two transport channels for the copper to enter into the enterocyte. One is the copper transporter that is mentioned here as if you can see, they are mentioned here as the CTR1, is the copper transporter 1. There is another transporter called as the divalent metal transporter 1. This divalent metal transporter 1 we would have previously read in patients with iron when we were reading about iron transport. So it is usually more commonly associated with iron transport into the enterocyte, but also it is also one of the transporters for copper from the lumen into the enterocyte. Once the copper enters into the enterocyte, it can either be stored in the enterocyte in a metallothionein form along with the metallothionein, or it can get excreted into the bloodstream. Now, when it gets secreted into the bloodstream, it is by means of an uh, adenosine triphosphatase called as the ATP7A. Remember, from the enterocyte, the secretion from the enterocyte into the bloodstream at the level of the gut is by means of ATP7A. So this ATP7A is very important because it is mutations in this ATP7A is associated with another disease, not Wilson's. It is associated with another disease called as the Menkes disease. It is more commonly seen in pediatric age groups, with patients usually present with growth delay and abnormal hair and epilepsy. And because of the abnormal hair, these patients are also known as the Menkes kinky hair disease. So that disease is particularly due to uh, pre- defect in the ATP7A, that copper is not getting secreted into the bloodstream. So once it is secreted into the bloodstream, it can combine with the albumin and other forms of transport proteins and get transported into the liver. Now let's get to know what happens in the liver. So once it reaches the liver, so here we can see that in the food and water that we consume, the copper gets converted into Cu2 plus to Cu1 plus, and through the copper transporter 1, it enters into the enterocyte. And then by means of ATP7A, it is entering into the circulation. Once it reaches the liver, hey, again, it enters into the enterocyte, enters into the hepatocyte by means of the copper transporter 1. There, this copper gets incorporated. There is something known as ceruloplasmin that is produced by the liver. This ceruloplasmin, when it is in the pro form, it is in the apoceruloplasmin, called as apoceruloplasmin, and it gets incorporated with this apoceruloplasmin gets incorporated with copper and to form ceruloplasmin. So here we can see an apoceruloplasmin being incorporated. This is the Golgi apparatus. So in the Golgi apparatus, the by means of an ATP7B. So by means of ATP7B, the apocytoplasmin gets packed with copper and forms a cytoplasm, which gets secreted into the various other tissues into the bloodstream, and it also gets released into the bile. And this released into the bile is also mediated by the same adenosine triphosphatase known as the ATP7B. So here there are two functions for this ATP7B. So we see there are two functions. The one is the copper loading of the celloplasmin into the Golgi apparatus and the excretion of excess copper into the bile. So we are going to discuss about what happens when this ATP7B is defective. So here comes Wilson's disease. Wilson's disease is a genetic disorder of copper metabolism. It is an autosomal recessive disorder where the ATP7B is affected. It is a membrane-bound copper transporting ATPase. As we know, it has two functions. One is the packing of the copper into the apocytoplasmin to form the cytoplasmin, and also the secretion of the copper into the bile. And this disease, when this both is involved, it forms copper toxicity, and primarily this involves the liver and the brain. If we go into ATP pathogenesis, we discuss it's the ATP7B gene is located on the chromosome. So if I can just move this thing, it will be much more clear. Yes. So here it's on chromosome 13q14, and any mutations involving this chromosome 13q14 will produce this Wilson's disease. What is happening? So there is defective copper incorporation into the apocytoplasmin and the reduction of the conversion of apocytoplasmin into the cytoplasmin. So this means that there is decreased levels of copper, and this failure of the copper excretion into the biliary canaliculi will result in increased levels of copper. And as we know, everything when in increased forms, this is a metal ion and will produce free radical damage to the tissues in the liver as well as in the brain. A lot of other tissues also that we'll discuss later. Now, going into the clinical features. In the clinical features, these patients usually have, mainly we discuss that it will affect the liver as well as the brain. So, in the hepatic involvement is usually the first. Patients can present with hepatic involvement or neurological involvement. It's almost the same presentations, either presenting with hepatic involvement alone is like 40% of the presentations, and only with neurological involvement is another 40%, and 20% of the time patients can present with a mixed type. So, but usually earlier presentations in the children or the pediatric age group, usually Wilson's presents in the hepatic environment, and they usually present in the mid to late teenage years in the West. But in India, we usually see these children presenting in a much younger age group, between even 5 to 6 years of age. And the more how much the younger the patient, that much greater is the involvement of the liver. And these patients can present it in any presentation, like they can present as a patient with acute liver failure, with highly elevated transaminases and coagulopathy and encephalopathy, or they can present with chronic hepatitis. They can present with also cirrhosis of the liver. So they can present any stage of the liver disease. When we go into neurological involvement, this neurological involvement is slightly just after the hepatic involvement. If you say this occurs in the teenage years, this occurs from 20 to 30 years is usually when we see patients presenting with neurological involvement. So around second to the fourth decade is the presentation of neurological involvement. And they can present in any of the three forms. They can present with Parkinsonian syndrome, they can present with dystonic syndrome, and they can present with ataxic syndrome. So sometimes we would have seen in patients who are being evaluated for young onset Parkinson's, Wilson's disease is a very common differential that we have to rule out in patients you are saying is a young age Parkinson's patient. And most of the time, it's not like this patient would be having this particular uh, type of disease. They would be having a mixture and will present with a combination of all these features. So that has to be remembered. It should not always be like it's not fitting into one. It can present in a variety of ways. So what are the common symptoms you usually see these patients with? So in neurological involvement, one of the most common symptoms that these patients will present with is slurring of speech. So we have mentioned here dysarthria. So this dysarthria is one of the most common symptoms in these patients. But just because a patient has some slurring, usually, and that too, usually it starts between the teenage years, people don't usually give much importance to that. And it gets missed until much more severe symptoms like dystonia or incoordination and dysphagia comes into picture. Patients usually miss these symptoms. So we have to be careful if any patient comes within a young age group between the teenage or the 20 to 30 years young group, we should be always thinking about whether Wilson's is a possibility. Because I had one patient who came to the OPD. He They didn't complain about it. He just came with complaints of giddiness. And but then he was speaking in a slurred tone. So I had to ask him, is there anything wrong with your speech? And he told me his tongue has always been the same way, and he's been speaking this way since childhood. So I was like, okay. But then something shined in from his eyes, and I just looked. There was a case of leisure, right? So we'll discuss about that. But I was just trying to tell you about how important it is for us to identify that dysarthria can be one of the common presentations of these patients. And then dystonia, any movement disorders. One of the first differentials for any movement disorders in neurology is Wilson's disease. It can present with dystonia, it can present with chorea, athetosis, any movement disorder, and tremors, any movement disorder for that matter. Wilson's is one of your treatable differentials. And incoordination, wing beating tremors, autonomic disturbances. These patients are common to have autonomic disturbances. They will have orthostatic postural hypotensions and they will have excessive sweating. Frontal syndrome in these patients are usually a neuropsychiatric symptom or a patient having impulsive actions and they lose their social inhibitions. Cognition will be impaired. And all this comes under the neurological environment, and usually frontal lobe is involved and hence called the frontal syndrome. Some patients can present. This is a little more less occurrence, but they can also present with seizures. So seizures is also one of the common occurrences for a patient with Wilson's disease. Now, this is an example of wing beating tremors. If you just look at the video here, so you can see it's a postural tremor. The patient, otherwise in his resting state, he is not having any tremors. But when he keeps his hand in this posture, he has a wing beating kind of tremors. And this tremors is very particular that it is um, very large amplitude, but it is slow frequency. It's not like a normal tremor. It's a very large amplitude and a slow frequency tremor. One more time, you can just see the video here to see the large amplitude and the slow frequency that is associated with this tremors. It's known as wing beating tremors, a postural tremor that is seen very commonly with Wilson's disease. Next, some psychiatric features. Another important thing to remember is psychiatric symptoms. Any patient in the young age group around 20 to 30 years of age, male or female, presenting with neuropsychiatric symptoms, before diagnosing it to be a functional cause, always rule out neuro uh, lupus and Wilson's disease. These two are very common differentials for a patient with neuropsychiatric symptoms, and they can present in this neuropsychiatric symptoms should not be missed. Once labeled, these patients will never be again diagnosed until further worsening and other symptoms develop in these patients. So always be careful to notice that in young patients presenting with around 20 to 30 years of age, always neuropsychiatric symptoms, always think about Wilson's and neuro lupus. If we go into the psychiatric features, these patients usually have temper tantrums. They get angry a lot, they shout, they have this crying bouts and then laughing bouts. They can have this labile mood. And then these patients can have depression. They can present with bipolar disorders, hyperactivity. They have sleep disturbances, irritability, and impulsivity in their actions. So, an acute psychosis can also be a presentation of Wilson's disease. So, it should always be kept in mind. We should also look for other features in any patient with acute psychosis. So, when you go into the ophthalmologic features, this copper that is getting excessively loaded in your body can get deposited in multiple places. And one of the locations it goes here is in your eye. When it gets loaded into the Descemet's membrane of your cornea, it's called something known as the Kayser-Fleischer rings. This Kayser-Fleischer rings, I'll show you an image in the next slide. It's golden brown color. It's a golden brown to brownish green color, and it's seen in the limbus of the eye. It does not produce much visual impairment, and it's very specific. Like 99% of the time, if case of facial ring is usually associated with neurological deficit disorder of the Wilson's, and only 30 to 50% of the time, a KF ring matches with a hepatic involvement. But 99% of the time, a neurological involvement will have a KF ring. And uh, sunflower cataract, when the copper gets deposited in the lens, it leads to something known as sunflower cataract. So I'll show you the images for the both. Here on the here we have this is the Kayser-Fleischer rings that you can see. This is golden brown to greenish brown uh, rings and the limbus. And then here you can see both. Here you can see the Kayser-Fleischer ring as well as the sunflower cataract. Now, this one of the close differential for a patient with for the KF ring is the what we have is the arcus senilis that we see in old patients. So, the patient can be presenting in old age also with Wilson's disease. We might not, so they might be presenting with cirrhosis of unknown etiology, not an alcoholic. We don't know what is the cause, and on evaluation we are suspecting Wilson's. So, how will you know whether it is an arcus senilis or as a patient is having a KF ring? So, always remember, arcus senilis will always be uh, complete. But case of facial ring is usually it develops in stages. So usually the superior limbus is the first, and then the inferior, and then the lateral sides get filled. So it's not always a complete ring initially. In the later stages, it will become a complete ring. But initially, it always starts with the superior limbus, then the inferior limbus, and then goes into the lateral and the medial sides and forms a complete ring. And but in arcus senilis, is always a complete ring. There is, and arcus senilis usually does not have a, there's no gap between the limbus and the sclera. But in Wilson's disease, there is always a gap between the ring and the limbus. There's always this gap, the normal gap between the limbus and the ring. Next, we go into the hematological manifestations. This is one again one of the types of presentations for patients with Wilson's disease. They can present as hemolytic anemia, but the important thing to remember is it is non-immune hemolytic anemia. So, a patient that presents with all features of hemolytic anemia, patient will be having indirect hyperbilirubinemia, patient can be having elevated LDH, patient can be having a normocytic normochromic anemia, patient can be having increased reticulocyte count in the blood, and patient can be having a decreased haptoglobin level. With all these features that is fitting into hemolytic anemia, if you send a Coombs test for this patient, Coombs test will come back negative, and one of the differentials for a Coombs negative hemolytic anemia is definitely Wilson's disease. So it should be kept in mind. These patients can come with an acute severe hemolytic episode or can present with chronic low-grade hemolysis. And next, renal manifestations. The copper getting loaded into the kidneys can affect usually the proximal tubules more than the distal tubules, and sometimes can present with Fanconi syndrome, where the patient will be having hypophosphatemia, loss of bicarb, and all electrolytes will be lost in the urine. And this is one of the manifestations of Wilson's disease in the kidneys. And this can also present with renal tubular acidosis, more proximal than distal, but it can present with both of them. And sometimes nephrolithiasis is also a complication that is seen with Wilson's disease. Next, if you see in rheumatological manifestations, in Asians, it is more commonly seen that joint involvement is more commonly seen in Wilson's disease in Asians rather than in the West. And they usually present with an early age onset arthritis and proximal myopathy. In skin manifestations, they usually, patients with Wilson's disease, similar to a picture in hemochromatosis, they also usually have a darker complexion with hyperpigmentation and bluish discoloration of the nails and acanthosis nigricans are all features of copper deposition in skin. Gynecological manifestations, these female patients can have primary or secondary amenorrhea in a patient with Wilson's. Now, one of the things that we need to see in a clinical aspect is when to suspect Wilson's. Not to suspect Wilson's just in every patient, and also not to miss if it is just staring at a face. So, we need to suspect Wilson's in patients who have unexplained LFT abnormalities. In a patient who is a chronic alcoholic and having LFT abnormalities that is matching with his alcohol consumption, we can suspect it to be directly alcoholic hepatitis. You don't need to work up for Wilson's. But in a patient who is not an alcoholic and who is presenting with an abnormal LFT with hepatitis kind of picture and having similar AST more than ALT by 2 times. That is again seen in a common picture that is seen in patients with Wilson's disease. So, unexplained LFT abnormalities, unexplained. Whether it can be explained due to something, okay, fine. But this patient is unexplained, does not have any metabolic abnormalities, and does not have consumed alcohol, has not taken any herbal medications, and has not taken any uh, we can't explain any other. The unexplained cases, you have to always suspect Wilson's disease. Young patients, yes, definitely you have to suspect Wilson's disease. A first degree relative with Wilson's presenting with any abnormalities like any neurological or liver abnormalities, always suspect Wilson's disease. A patient with chronic liver disease or cirrhosis that is of unknown etiology, when you're working up the patient, always suspect Wilson's disease. An acute liver failure with other features, again suspect Wilson's disease. Wilson's disease should be in back of your head in a patient with acute liver failure also. Unexplained neuropsychiatric symptoms, as I told you, young patients who present with acute neuropsychiatric symptoms, Wilson's disease and neurolupus should always be part of your diagnosis. Now, for diagnosis. So in a patient, this diagnosis we divide into two. In a patient who has a KF ring, diagnosis is a little more clearer. And this KF ring, usually can it can be actually visualized by naked eyes also. Or in some patients, it might not be at that stage where it is very much visualized, just by looking. So you might use the slit lamp examination also to look for a KF ring. Now, if it is confirmed by a slit lamp examination or by your BRI examination that there is a KF ring, then the cutoffs are slightly lower. Like we definitely for any patient for working up for Wilson's, you need to do serum ceruloplasmin as well as 24-hour urinary copper levels. So these two are very important. And once you do a serum ceruloplasmin level, the cutoff is 20 milligrams to less than 20 milligrams per deciliter for a patient who has KF ring. And if the patient has a serum ceruloplasmin, low serum ceruloplasmin, then you can confirm it by checking the 24-hour urinary copper levels, and it needs to be just more than 40 micrograms per 24 hours. And if it is more than 20, for 40 micrograms per 24 hours, you diagnose the patient as Wilson's disease. But if it is less than that, then you will need to do further testing by liver biopsy or any genetic testing. Here again, we go into a patient where the ceruloplasmin is not low. So I told you with KF ring, the cutoff is less than 20. So here it's not less than 20. So again, you check the 24-hour urinary copper. Because ceruloplasmin is not low, we need a higher cutoff for 24-hour urinary copper, and we see if it is more than 100 micrograms. If it is more than 100 micrograms per 24 hours, again, we diagnose as a case of Wilson's disease. If not, if the patient's 24-hour urinary copper is less than 100 micrograms per 24 hours, then you obtain a liver biopsy. And then you check for the copper level in the liver biopsy, which is a gold standard, is to check for liver biopsy and check for the copper levels. And if it is more than 250 micrograms per gram of a dry weight of liver, it is confirmed to be Wilson's disease. In some patients, when the liver biopsy is contraindicated due to any bleeding abnormalities, any coagulopathy, or patient is not stable enough to go for a procedure like that. Genetic testing is also a very good test to identify that ATP7B mutation that is seen in the chromosome 13q14. So, in those patients, we can go for obtain the genetic testing. In patients where liver biopsy itself is not revealing a proper diagnosis, also you can go for obtaining genetic testing. Next, in patients who do not have case separation rings, but you have a patient with liver involvement, again you do the serum ceruloplasmin and 24-hour urinary copper levels. Here, the cutoff is again lower. Like serum ceruloplasmin is less, should be less than 10 milligrams per deciliter. Only then you can diagnose the patient. And then, if yes, then 24 urinary copper levels should be more than 100 micrograms per 24 hours. And if yes, then you have a diagnosis of Wilson's disease. No, again, you have to obtain a liver biopsy here. Similarly, here also again the cutoff is 24 urinary copper excretion less than 40 micrograms per 24 hours. You have to again go for a Wilson's disease excluded. If it is more than 20, 40 micrograms, then you can obtain liver biopsy and check the dry weight. Again, it is for establishing a Wilson's disease, you need to have a dry weight of copper levels of more than 250 micrograms per gram of dry weight of liver. Diagnose patient to have Wilson's disease. Next, a neuroimaging in Wilson's disease. If you see here, it's one of the most common named signs in neuroimaging in MRI is the face of the giant panda. So here you can see a panda, and you can see that face of the giant panda here. It is basically a finding that you see in the due to hyperintensities in the midbrain, where the copper gets deposited, and then abnormal T2 hyperintensities in the putamen is actually the most common finding on a patient with neuroimaging in Wilson's disease. But one of the most common named signs is the face of the giant panda seen in the midbrain of the brain. Next is treatment. So initially we discussed what are the most copper containing food. So we discussed seafood, which contains shellfish and all the other things. And then we discussed about nuts. We discussed about potato, green leafy vegetables, chocolates. So all these foods should be avoided in these patients. And dietary modification alone won't be able to manage a patient with Wilson's disease. And you need specific treatment according to copper specific treatment for these patients. And this treatment should be lifelong. It should never be stopped. It should be lifelong because patient will have copper loading in for lifelong. So you need to have a copper specific treatment also for lifelong. Patient and family education is important. Genetic counseling is important because it's an autosomal recessive. Uh, Preventing consanguinity is also very important in these patients to prevent further and further development of the diseases. And symptomatic treatment for the psychiatric, medical, and hepatic and neurological manifestations is important. When patient presents with acute psychosis, just copper specific management or dietary modification is not going to help the patient. You need symptomatic management for the patients in acute liver failure or in neuropsychiatric emergencies. You need to do the specific management accordingly symptomatically. Next, going into the dietary monotherapy. So we'll avoid the food that is rich in copper content, as we discussed before. Avoid cooking and taking food in copper-containing utensils and plates. That is uh, self-explanatory again. Immunization, because it affects the liver. It is better to get a immunization with hepatitis A and hepatitis B in these patients for seronegative patients in Wilson's. And also abstinence from alcohol is must and must. Next, going to copper specific treatment. In patients who have, it is divided into two. If a patient has symptoms or organ damage that is established, you have to go for a copper chelating therapy no matter what. There is nothing other than copper chelating therapy for the treatment. If patient is asymptomatic or has no signs of organ damage, then you can go either for a copper chelating therapy or you can treat with zinc. Now let's see how these mechanisms of action, how they act. So in copper chelating therapies, the most commonly used is the D-penicillamine. Um, the D-penicillamine is removes the copper from the less tightly bound copper from other tissues, and they promote the renal excretion by making it more renal soluble. So the dosing is 250 to 500 milligrams once daily, and then you increase this every 4 to 7 days. You increase the dose by 250 milligrams, and then to a maximum dose of 1,500 milligrams per day, which is given as a once daily dosing penicillamine. This penicillamine, if you are using for a long term, and we are going to use for a long term in all these Wilson's disease patients, it is better to add pyridoxine because it can cause B6 or pyridoxine deficiency. It is always better to add pyridoxine supplementation in the dosing of 25 to 100 milligrams, 25 to 50 milligrams, sorry, from per day. Now, some adverse effects. D-penicillamine is a very good drug, but there are still adverse effects also associated with D-penicillamine. And one of the most important adverse effects that you see is in patients with Wilson's, especially neuro Wilson's. Once you start D-penicillamine, they might have an exacerbation of the neurologic disease. This could be because of the mobilization of the copper from the liver, and the mobilized copper from the liver just gets into the circulation before going to the renal excretion. They go into the brain and then gets deposited there and causes an exacerbation of the disease in the neurological disease. So that's one of the possible explanations for why these patients have sudden neurological deterioration. And in case this patient develops a sudden deterioration, then you are supposed to stop D-penicillamine immediately. And this is not seen with all patients with neurological disease. Only approximately 20% of these patients with neurological disease develop this acute exacerbation following the D-penicillamine therapy. Sometimes D-penicillamine acutely can produce a hypersensitivity reaction also in renal involved, some patients will develop proteinuria. So it's very important for patients who are on D-penicillamine therapy to have regular urine routine monitoring for albuminuria and proteinuria. And if they develop, it's supposed to stop D-penicillamine before the patient progresses into a very severe form of nephrotic syndrome. Bone marrow toxicity. So D-penicillamine can also affect the bone marrow and can produce suppression of the bone marrow. And it is supposed to be stopped when the WBC counts is less than 3,000 and when the platelet count is less than 80,000. This is the cutoff for stopping D-penicillamine therapy in patients who develop bone marrow toxicity secondary to it. Skin changes can also develop in D-penicillamine therapy. Next is trientine. So in patients, trientine also acts with the same mechanism. They also remove the copper from the less bound tissues and promote their renal excretion, but it also has an additional action. Those when you take the trientine orally, the unabsorbed portion of the trientine from the gut will bind to copper again and also block the intestinal absorption. So it has two mechanisms of action. One is the increasing the renal excretion of copper from the body as well as preventing the absorption of copper by the non-absorbed form of trientine. The dosing here is 15 to 20 milligrams per kg per day and divided in 2 to 3 doses, and it has fewer side effects compared to D-penicillamine. And in patients who develop neurological exacerbation following D-penicillamine, you can consider trientine as a possible uh, supplementary agent. Next, going into zinc. Zinc, it interferes with the absorption of copper from the gut. So it induces something known as the enterocyte metallothionein and keeps the copper bound in the enterocyte, and thereby it's not getting released into the circulation by the ATP7A. So it prevents the absorption of copper at the level of the gut. So that is how the zinc acts, and zinc is dosed at 150 milligrams in three divided doses. Remember, zinc can also produce dyspepsia, worsening liver and neurological disease. It can also produce something known as a raised amylase and lipase levels in the absence of pancreatitis. But zinc, the exacerbation of the hepatic and neurological disease is less compared to D-penicillamine. So we usually prefer to give zinc in patients who are having no organ damage or completely asymptomatic patients. You usually try to start the treatment with zinc. Now, finally coming to what is our treatment goal? We are looking for symptomatic improvement. So once we start treatment, we need to assess the symptomatic improvement, whether the patient's symptoms are getting worse or improving. If they are getting worse, probably the treatment could be the cause, then we need to stop the treatment immediately. Or if the and it's still not improving, then we need to change our treatment and plan. So symptomatic improvement is one of our treatment goals, and the other is to look for liver enzymes to come back to normal. So normal and near normal serum aminotransferases is our treatment goal. And finally, coming to copper levels, 24-hour urinary copper is what we use to monitor the uh, effective treatment. And in patients who are started on zinc, you look for a 24-hour urinary copper level less than 100 micrograms per 24 hours. And in patients with D-penicillamine or trientine, that usually we start in patients who are having severe disease or organ damage. And in these patients, you look for a cutoff around 24-hour urine copper level to be less than 500 micrograms per 24 hours. And initially you can do this every monthly, and then once the patient becomes more stable and his levels of copper has been controlled, you can change the monitoring to 3 to 6 months, and then later yearly. So this is all about Wilson's. I think we have discussed most of the things regarding Wilson's. There are other therapies that are coming up, but these are the approved therapies as of now. So we've not discussed about the upcoming treatments and therapies, but these are the approved treatment, and I think this would give you a complete picture of Wilson's disease. Uh, until next time, thank you. Bye.